Good evening, everyone. Dr. Robert Horowitz here. I want to welcome you for this evening. We are going to talk about dental implants. We're going to talk about socket grafting. We're going to talk a little bit about guided surgery. Most important is to be sure you put questions in the chat, in the Q&A at the end, because I'm here to answer your questions. I'm going to show you some cases, some philosophy of how to treat patients. And I want to be sure that your questions, as many as we can get to, are answered. And if not, please feel free to email me. I want to thank our sponsors, Vivo Systems and the implant company that you're going to see the implant we're working with later. And let's get rocking. So, when do you start to prepare a patient for an implant? Is it after you have a socket that's bleeding and looks like you might be able to do an immediate socket implant or a graft? How do you decide? When do you decide it's time for dental implants? What are your goals, either as the surgeon, the restorative dentist, or as a part of the team? Or if maybe there are hygienists here, or endodontists who are not involved in implants. All sorts of dentists have different parts of the puzzle to play. What are the patient's goals in dental implant therapy? What does a patient really know about implants? They generally only know a few things. It hurts, it costs, and they know if the tooth ends up being in the right place and functions properly. My goal as a periodontist is basically to be invisible. It's to make a foundation for a restorative dentist to make a quote unquote tooth that looks, functions, feels, and fits like a regular conventional tooth with keratinized tissue around the margin so that the patient, when no one of their friends, family, work colleagues can see the difference between that and any others. How do you get them to coincide? Well, we have maybe 45 minutes of images to take you through, maybe a little more, maybe a little less. And we'll talk about some of my ways to get there, and then we'll answer your questions and see if we can get them to coincide. So, to me as a periodontist, implants are not always the answer. And without getting into any very heavy philosophical discussions, if we think about how long teeth have been around, they've basically been around in humans for 4.5 million years. Dental implants have been scientifically researched for about 70. We still have a tremendous amount to learn about dental implants. For instance, why might you have a patient where all of the implants, whether they have 2, 4, 6, or 10, are doing well, except one? Bite is the same, home care is the same, function is the same. They can even be the same or different implant surfaces. They can be the same or different socket grafts, barriers. We don't really know. We are getting better and better as periodontists at saving teeth, but sometimes when an implant goes south and starts to lose soft tissue, hard tissue, not always as easy to rebuild. So we need to know also about peri-implantitis, which stems from a risk of periodontitis, smoking, diabetes, and other factors. So this is also something that patients aren't always told about. And that is if they lose their teeth to periodontitis, they're at a higher risk for losing dental implants. So again, something for everyone in the dental implant team, from hygienist through surgeon and restorative dentist, and even the front desk staff needs to be aware of. So just a little bit about me. As of this coming December, I will have been studying dental implants for 38 years and placing them for about 37 3/4, and had a lot of experience with a lot of different systems. I teach primarily at NYU in the Department of Oral Surgery, but I have other appointments at the school, other schools in India, and I also have some appointments through the International Association of Dental Specialists. And if there are any specialists on board who are not yet members, send me an email. I'd love to talk to you about it. So, where do I start talking about dental implants? I look at every single patient who comes in and figure out how I can save their teeth if they start out like this, which teeth look like they're going to stay for the rest of the patient's life, and which may actually not, which teeth are at higher risk. So if we think about numbers, we can look back to Schillingberg's textbook from forever ago, and we know that the first molars generally hold up about 85% of the occlusal forces. Well, let's see, they've been in the patient's mouth functioning since they're 6. Generally, the patient then has the worst home care. And as you can see from just this one image from our intraoral scan, those 2 lower first molars don't look like they're in great shape. They have some buccal amalgam restorations. They look like they may have some crack and craze lines. And if we look at the upper first molars, even just from these views, we can see recession, furcation involvement, possibly some decrease in the amount of keratinized tissue. So all of these factors are putting the patient at periodontal and restorative risk. Now, if we look from the occlusal surface at those upper and lower molars, we see crack lines, we see large restorations, we see things that make us very concerned. So even if the patients do not have dental decay at this point, even if they do not have sensitivity on those teeth, even if the x-rays show fully normal teeth, this is the kind of patient that I start talking to about dental implants. Because if these teeth get vertical root fractures, they are not going to be able to be saved by even the best endodontist in my neighborhood. And I'm lucky to work with some very fine specialists, endodontists, restorative dentists, and prosthodontists to help me save a lot of my patients' teeth. But once there are vertical fractures, there's really not much that we can do. And I'm not sure that teeth like this that don't present with dental decay, that don't have any sensitivity, that most patients are going to say, yeah, I'll take my chances and I'll leave those amalgams that have been in there for 30, 40, 50 years and not go for full coverage restorations at this time. But again, these are discussions that you have to have with your patients. Are they willing to roll the dice and say, you know what? I'm going to be good. I'm going to be good about my home care. I'm going to be good about coming in for professional cleanings. But they have to understand the risk factors, that fractures in these teeth will often lead to need for extraction and replacement of dental implants. And again, as we look from different angles, we can see where those crack and craze lines are and how this patient really is at risk if they don't have an ideal occlusion, if they possibly aren't wearing an occlusal guard at night, maybe when they do heavy sports, if they do weightlifting, things like that that could really stress the teeth in lateral functions, which teeth are not designed to take. These are the times that we have to worry and be concerned about our patients' teeth, especially ones that look like they're in this precarious situation. So let's talk about a hopeless tooth. And there are many patients that have teeth that are hopeless, that are taken out, that maybe in my office where I work in a pretty nice suburb of New York City, I can save, given the right amount of money, the right amount of dental IQ, the right amount of patient emotional involvement in their tooth, and the right involvement in the appropriate number and ability of dental therapists that I can bring to bear. But here, to me, are some relatively absolute conditions where I think a tooth has to go. If they have a long-standing perioendo lesion, if they have a deep horizontal fracture, or one that's going to compromise the aesthetics, the function, or maintenance of an adjacent tooth. If they have severe root resorption. I know there are some very talented endodontists who can do wonders with MTA and some of the other magical powders that they have, but not everyone can do that, and not every patient has access to those specialists. Furcation lesions are the hardest. Yes, we often will try these days, which had gone out of fashion for a while, we will try and do root resections, and we will try to save one tooth and go back to our old perioprost days. But again, we need a patient that is motivated, has a high dental IQ, and has the ability for personal and professional maintenance to take care of those teeth. So deep perio pockets. Yeah, one day we'll get into some of the really cool stuff that we can do with perio. But again, that depends who the patient sees. If they're seeing a restorative dentist and a hygienist that don't have the access to the latest and greatest periodontal materials, there may be a difference between them saving a 3 millimeter infrabony pocket and me saving a tooth with a 10 millimeter infrabony pocket. What else? Pain. If we can't find the source of pain, it usually means a root fracture or an endodontic failure that can't be retreated. Progressive mobility. Sometimes a tooth is just so loose that we can't save it. And if caries are deep and into the furcation, if the tooth can't be retreated endodontically, and then again, there are teeth that are sometimes in the wrong place that can't be orthodontically repositioned. So these are a number of things that you should keep in your head where teeth really can't be saved. But there are also some modifying factors. Some of these teeth may be questionable in a younger patient, but in an older patient, we may save a looser tooth or a tooth that may not be in the ideal aesthetic or functional condition or in the ideal location, because they may not be a good surgical risk either to rebuild the periodontium or to take it out and place an implant. Like my mother's oldest best friend, who's 92 years old next month, who came in today, who really wanted to save her upper premolar, even though it was fractured down to the gingival margin. So we also have to look at the perio and restorative conditions of the whole mouth and the adjacent teeth. How much opposing occlusal load, how much adjacent occlusal load there is, and will the patient be able to maintain the tooth long enough if we're going to try and save it? What about the restorative needs of the tooth? Again, if the tooth may just need a filling or doesn't need anything, then we don't have to worry as much about it as if there's a deep perio pocket on a tooth that now may need endo, a post-core and crown. It may change the balance of the scale and tip it more towards the extraction phase. And again, pain. Pain, swelling, conditions like that make us get off the couch and make our decision more quickly. So what about the team you have together? Again, there are newer materials, restorative, endodontic, surgical, that can give us the ability to save a tooth longer if the patient has the time, emotional investment, and finance, and access to teams that have these. Depends on surgical skill, depends on the biological and physical materials that are used. And again, can the patient clean it if the tooth is not too mobile? Also, sometimes there's luck. Sometimes we do the same thing twice, and one time it works perfectly, and one time it doesn't, and we just don't know why. So for me, here is the absolute of when a tooth is hopeless, when it can't support the functional load that's desired of it for the longevity of the patient. That's when I decide it has to go. So let's take a patient who came in recently. Now, here's what's fascinating to me. The upper left has implants. The lower left has implants and natural teeth. The lower right has natural teeth and a non-restored implant. And the upper right is an absolute disaster. So what we've said about periodontal disease for years is it's site-specific, episodic, and who knows when it'll strike. Well, this is a combination of periodontal disease, caries, and endo problems. So he has had, as you can see, even in the upper arch, his share of trouble over the years. So let's look a little more closely. Look at tooth 3, where that mesiobuccal root has decayed and fractured out and is wandering around somewhere. Look at tooth number 4, where we see whatever is going on there. Look at the site collapse in the buccal of number 4. Look at 5 and 6. Look at the lack of keratinized tissue. Even with his very good home care on that second molar all the way in back, you can see how much inflammation there is everywhere else. So we have some factors here that are mitigating the situation. This patient is a lovely, very bright, very fit man in his early 80s who is a law professor who teaches 1 semester near me and 1 semester in Europe. I don't have a lot of time and I have 0 follow-up, as you're going to see. So we know this is not something that happened yesterday. So somehow his dental team let him get into this condition. And here's that lower implant that not only has never been restored, but doesn't even have the right healing abutment on it. So one of these days we'll get him to get that restored. So here's a better look at the upper right. So we can see the tremendous amount of decay on that canine. We can see where that mesiobuccal root of tooth number 3 has actually drifted into the site of number 4, where part of it fractured. Or maybe that's the root of number 4 that's just wandering around there, and where there's a defect in the ridge on number 5. We can see that tooth number 2 is non-vital, has caries. 3 we know has caries. So we know this patient is in a really severe state of neglect. So what do? Tooth number 8, that whole bridge has class 3 mobility. There's a periapical lesion there. To save one tooth that has a shortened root, very tapered root, that is going to need endo, has decay down below the gingival margin, does not make sense in this patient when we're looking at implants in the whole sextant. So what do we start with? We have to figure out how to get him out of pain, how to remove the offending teeth, how to rebuild bone and gingiva, and do that in such a way that he can get a removable prosthesis, wear it when he's teaching, and wear it when he's 3 or 4 or 5 or 6,000 miles away from myself and the restorative dentist. So again, everything from 2 to 8 on the upper right is hopeless. We saw where there's significant bone loss on 3 and 4. There's also complete site collapse in number 7, where that was extracted. We saw the lack of keratinized tissue in the area. And what I'm looking for is not just rebuilding, like filling potholes, but I need vital bone. I need keratinized tissue. I need the body to have what it needs for osseointegration of dental implants and aesthetic and functional support around the restoration, and as well the ability to fight off periodontal and peri-implant disease. And I need it to be predictable and have it heal under a removable partial when no one is there to look at it and maintain that partial. So that's what we have. That's just 6 and 8. So again, now you can see 6 is fractured, and we saw the x-ray totally decayed. We know that 8 is fractured with no supragingival structure. You can see where there's no tissue at all on the volume at 7, and you can see what's missing already at 5. So I have one surgery. I can't do multiple surgeries. If I lay a flap, what happens? What do surgeons like Fickel and Hertzler tell us if we elevate a flap at the time of tooth extraction? Well, we know a lot of people want to do that for surgical access and to get primary closure over the extraction site. But what does that really do for us? Do we have studies? And yes, Fickel and Hertzler showed us that if we elevate a flap, we're going to lose more bone than just a conventional extraction, even if the site is grafted. So that means if I want to regenerate the bone in the site of 7, it may come at a cost of decreasing the volume in sites 6 and 8. And look at 2 and 3. So at this point, even just taking off that bridge took out the palatal root of 3. But I'm going to leave tooth number 2 literally as a crestal seat for that partial. I want to do anything that I can to prevent that partial from seeding and causing pressure necrosis of the soft tissue and from damaging my hard tissue regeneration. Again, you can see how deep the decay and the fracture are in tooth number 6. So think about the instruments you have. Think about a number of the companies that are out there that have incredible instruments for this. We're trying to keep this as non-biased as possible. So email me questions and I can send you suggestions of some of the stuff that I use. So again, this did not happen yesterday. He didn't all of a sudden eat 12 cases of chocolate bars, 5 gallons of caffeinated soda with sugar, and this just decayed overnight. So the neglect to me is on both a personal and professional level. We see the volume of bone loss on 7, on 5, and we know if the sockets are not treated properly, we're going to lose a lot more. So again, what do I want? I want regeneration. I don't want to just fill the holes. I want to biologically replace the tissues in the hole and over the hole that he needs for functional and aesthetic support of his dental implants. So what do I need preoperatively? First, I need a consultation. I need to talk to him. I need to talk to his restorative dentist because I don't work in a vacuum. I work with a team. So I need to work with his restorative dentist and say, look, here's the plan. We're going to take out the entire upper left side except number 2. I'm going to need you to get him a partial ready for him to come to your office that day where the crestal portion is not metal, but has enough acrylic that you can relieve it because I'm going to try and gain height and width of bone and soft tissue. And we need to plan all this together. The patient needs to know that he's going to have to wait at least 4 to 6 months. At his age, I want to give him extra time to heal before I place the implants, and then probably another 6 months between his schedule and his age before they can be restored. So what do we do to the socket? If we do nothing, what happens? We've all seen it in our patients. Those of us who teach in school see it all the time. You see a patient come in with a knife edge ridge with no keratinized tissue. Well, that may be one thing for a lower denture, which is not going to really seat well and stay well. Luckily, it'll have gravity to help. But what about that maxillary right central? That's going to be an implant right next to a natural tooth. We have to have an idea of what happens, what the literature tells us will happen if we don't graft and if we do graft. So my friend Henry Greenwell down in Kentucky came out with a great paper on socket grafting versus non-grafting. And they studied this in non-molar teeth, and they took teeth that had very similar plaque index, gingival index. So they all started out with very similar periodontal conditions. And just get an idea from this table of what happened horizontally, how much bone was lost. So even in the places where they placed the mineralized allograft, yes, in this case, they hydrated it with a dilute tetracycline solution. They went from 9.2 to 8 millimeters on average of ridge width. But how about where they did nothing? That's more of what we're used to seeing, 20 to 30% in only 4 months. And that's going to continue to collapse over time. So what about ridge height? What did they lose? When they grafted the sites, they lost 1 to 2 millimeters all over the place, even where the site was grafted. But where the site wasn't grafted, they lost 2 to 4 millimeters of bone. So imagine you take out a tooth on a patient and say, yes, Mr. Smith, Mrs. Jones, Mr. and Mrs. whoever, we're going to evaluate it in 3 to 4 months, and then either we or the surgeon will place an implant. Well, now let's say you send that patient to the surgeon, or you plan on doing it yourself, and find out the patient needs a ridge augmentation. That could add $4,000, $5,000, $6,000. That could add 6 months to the treatment. And what if you never informed the patient that that was a possibility beforehand? Not a very good situation to find yourself in for building up yourself in the eyes of your patient. What about if we look histologically? What happened? Well, if we look at vital bone percentage in the non-grafted site, so that's where there was just a blood clot, they found 50 to 60% vital bone. Again, that came at a cost. Yes, there was a lot of vital bone there, but they lost a tremendous amount of volume. Where the site was grafted, It was literally a third, a third, a third. A third residual graft, a third vital bone, and a third connective tissue. So with this particular set of material, only about 2/3 of the socket was filled with mineralized material, but only half of that, 1/3 of the socket, could really participate in osseointegration. And if we look at some of the other studies, Lekovic and Simon, they found a little bit less horizontal and vertical change in their studies than this study. And if we look at extraction alone, Lekovic found more horizontal change on average than the current study did, and about similar amount of vertical change. But again, look at Lekovic's numbers, and they found 4.5 millimeters of loss of horizontal width. So if you take an average molar that's 10 millimeters wide, you're going to end up with a 6 millimeter ridge. Is that really where you want to put your dental implants? So again, in this study, at only 4-month time frame, there was 13% loss of width in the grafted sockets. The untreated sockets lost 1/3 of their width. Again, we talked about the graft, roughly 1/3 vital bone, roughly 1/3 residual graft, as opposed to almost 60% vital bone in the non-grafted sites. But again, those non-grafted sites lost so much bone that you might not have been able to place implants in every site, or if you did, you might have had threads exposed. What was one of the big issues? Flaps were elevated in these cases. So again, as Fickel and Hertzler said, as Magatis and Stahl showed in 1984, you're going to lose bone every time you elevate a flap. So what do you want to do? You want to know your dental anatomy. You want to section multi-rooted teeth. You want to elevate whenever possible and do anything you can flaplessly. Only elevate a flap if you absolutely have to for access to debridement or to try and gain extra alveolar width, like you see here in the site of 7 and 6, where 6 was defective. Just going back for a second, you can see that knife edge, that paper thin bone around the socket of number 8. That goes back to Hyunba and other studies that show in the premaxilla, in the aesthetic zone, the width of the average buccal plate is less than 1 millimeter in 87% of cases. That's why we see so much site collapse. So again, if we leave the socket alone, we learn in longer term studies, 40 to 60% of the width, not necessarily height, but Pietrkowski and Massler showed that more in denture patients. Yilmaz showed 25%, Mish showed 25% width reduction in 1 year, and Yilmaz 1.35 to 2 millimeters in loss of height. So these are numbers that you should know, not that you're going to be tested on them, but this is why you need to convince your patients that maybe just having a tooth extracted without a graft is not in their best interest, whether or not they're getting an implant. If they're getting a fixed prosthesis or a removable prosthesis, you still want to maintain bone and keratinized tissue under it. So here are the sockets, and again, you can see those beautiful silver points. We're maintaining tooth number 2 as a denture seat, and we're placing allograft in the site. We're mixing it with platelet-rich fibrin. We're going to make a block or sticky bone, hydrated first with liquid from the red tubes, then the white tubes, so that the graft material will keep its shape. So what does platelet-rich fibrin do? It will release growth factors. It will have some effect on the ridge preservation, but according to statistical studies, it's not going to give me more vital bone. So clinically, it makes us feel better. The flaps heal quicker. The soft tissue looks better. But statistically, there's not more vital bone. So in this case, what we did, we put the block of bone. We have our amnion-chorion barrier, which we're going to place over the graft, which we're going to make to ideal contour. And then I'm going to put platelet-rich fibrin over that to give us a little bit of extra assuredness that the flaps will stay closed, because I'm not going to be seeing him for post-ops. I'm not going to be there to make sure he's keeping everything clean and not picking at the sutures or playing with the flap. So again, everything is over contoured to ideal, covered with our amnion and chorion barrier, platelet-rich fibrin, and you can see we're really going for it. We're not letting these sites collapse. We're trying to maintain in sites 6 and 8, and we're trying to rebuild 7, 3, 4, and 5 to ideal contour. We're trying to maintain the height and increase the width of the ridge everywhere we can. So these are the images grafted. That's the initial CBCT, the 3D view. And again, you can see the tremendous damage in sites 3, 7, and 4, and how there's absolutely no bone on the facial in those areas. So that was the initial graft. Again, trying for absolutely everything. We're going for a home run. We do thorough debridement. We're doing the PRF block of mineralized corticocancellous and cancellous allograft. Amnion chorion barrier over it, PRF over that. And look what we got. We have thick, wide keratinized tissue. We have wide alveolar ridges. We have everything we need. Look at all of that bone we got, almost up to the shoulder of tooth number 2. It looks like we got healing above the crest of the ridge in some of these areas. So we got an increase in bone. We got preservation in bone. We have more keratinized tissue. And look at the width of that ridge. So there we are in 6 and 8. We have plenty of height and width to place dental implants in those sites. In 3, 4, and 5, we could place them there as well, but we're not going to place one in site 3 yet, because that would be a little too close to the mesial buccal of number 2. But again, you can get an idea, you can appreciate even where there was no bone on the mesial and buccal of 3 and 4, we've rebuilt to full contour. PRF block of mineralized corticocancellous allograft, amnion chorion barrier, platelet-rich fibrin, just to ensure, since he was going away, that the flaps would stay closed. So now we work with Marius and his team, who are doing our surgical planning for us. Yes, we do it together. We are going to plan the size and shape of the teeth. We are going to plan the angle and directions of the implants. It starts with the prosthetics. We do prosthetically guided bone regeneration and then prosthetically guided implant placement. So we do an intraoral scan. The team merges it with the CBCT. It takes time. It's going to save us time at the surgery. The surgical guide is expensive. It's not a money-making proposition to do guided surgery. We don't have the patient pay for a surgical guide as an extra line item so we can make more money. We do it because we can get more precision of our restorations. What do we want to do? We want screw retained whenever possible. So if we've been able to generate enough bone to get implants in the right position, we can get them in more quickly, more easily, and more ideally for screw retained restorations. So this is our goal. That is where we want our screw access holes. And we may or may not place them in every site except number 7. So on the left side of your screen, you can see the central access line of all of the teeth as Marius and I have planned them. And on the right side, you can see in the Panorex where they're located. And you can see in the cross sections starting to appear in the bottom on the right exactly where they are. Tooth number 3 and others. This is tooth number 8 now. And again, that is 100% preservation of the alveolar ridge. Yeah, and you can see it with this software that we're using in every angle. So again, what did I say my job is at periodontist? First of all, my job is to work with the restorative team to help them educate the patient on what ideal is and what ideal treatment is. But in this case, it was to first get guided bone regeneration, guided keratinized tissue regeneration, so that after the implant is placed appropriately, we can then have the patient get ideal restorations. And if you look even at the cross-sectional design of this implant, even in schematic, you can see it has aggressive threads. You can see we're going to bury it, not just for prosthetic running room, which is important, but also you can see that it has a narrower shoulder, and that narrower shoulder will let us build more bone at the alveolar crest. It will give us in that running room the ability to generate more soft tissue. Boozer and Grunder have always said that we want 2 millimeters of alveolar bone, buccal and lingual, and in every direction around our implant. Although they don't have studies to prove it, makes sense because that way we can get marrow spaces with a blood supply. But Linkevicius in his studies has shown that we want 3 millimeters of keratinized tissue. So I was able to rebuild the bone in the gingiva, as you can see in these cross sections. Will we get regeneration? We'll find out. And the goal, again, is screw retained whenever possible. We want to have retrievability. We want better access for the lab to design the appropriate restorations, and we don't want cement. We want to do this as a team. Myself, the restorative doctor or doctors, the lab, and the patient, all to get the same desired outcome. And if I do it right, I'm invisible, and their work will shine. So look at the ridge. We got 7 back. We got 3 and 4 back. We have everything we need to place implants where we want them. We have our guide designed by Marius and team, printed so that we can use our guided surgical drills to get appropriate length, width, depth, angulation. We can get irrigation in there so we're not overheating the bone. We have everything we need to do to get implants placed for ideal screw retain restorations. We can do the surgery much more quickly than we can do freehand, and we can get the implants placed perfectly so they can be loaded appropriately and maintained appropriately. So we're going to use allograft like we did in the sockets, because allograft, in the absence of growth factors, i.e. platelet-derived growth factors or other ones, will turn over more quickly and give us more vital bone. And again, just another view showing how the guided drill is going all the way to give us the exact placement of the implant where we want it. And there are those implants in 8, 6, 5, and 4 sites. We have it designed for 3, but we're probably going to redesign our surgical guide after tooth number 2 is extracted, and we have sites 4 to 8 temporized. So the implants that were placed have a very clean osteophilic surface. The contact is an implant from France. Aggressive apical thread, which in regenerated bone, in the soft bone of the maxilla, will give us very, very good primary stability. The cylindrical body is solid. It's not tapered all the way through, so it gives us very solid implants. Some of these implants went in with an ISQ measurement of 79 and 80. Its bone platform shifted at the crest. So like I said before, we bury it 1.5 to 2 millimeters deep, so more bone can cover over the crest and start giving us the running room and the emergence profile. And it's stable everywhere. And look now what you see here also, all that keratinized tissue that we were able to regenerate. Implants are lined up prosthetically. We're going to bury them again because he's going away for another 6 months. I think last time was Malta and this time is Spain, and he should be back in about a month for me to uncover them. So now you can see where those implants line up on the Panorex. And that was 1 week, maybe 2 weeks post-operatively when he was getting ready to go on the airplane. and head off. But again, look at all that thick, healthy keratinized tissue that's going to be on the facial of our implants. So now he knows what's going to happen. When he comes back from this trip, he'll get uncovered, he'll get healing abutments, he will get, I actually even scanned him initially. So if the restorative dentist wants, he can even have a provisional restoration made or a verification stent so that he can move forward very quickly. So this just came in this week. Site number 4 that had 0 buccal plate, had 0 bone width, an all regenerated bone. We have about 30% vital bone. Site number 6 that was missing half of the bone, period, missing most of the buccal plate. We have 45% bone, 45% mineralized content, I should say, and about 60% of that is vital. And site number 8, where we had that very, very thin buccal plate, but managed to preserve it all, we got 85% bone. Just to give you an idea, in this part of the maxilla, the amount of vital bone is normally 35%, and that is good, thick, healthy bone. So very quickly, I want to just show you 2 other cases. This is Brendan, who is just actually in today. We're going to take out 30, not 31. 31 we're going to try and restore and keep. You can see the large PAPs and the furcation involvement on 30. And you can see just how his teeth are all over the place. He's going to go into orthodontics as well. So again, to me, the first instrument I use when I extract a multi-rooted tooth is a cross-cut Fisher burr. I decarnate about 1 millimeter supragingivally and then section the tooth. That enables me to do this in a flapless manner because I know the anatomy. I can rotate slightly to start loosening the PDL. I try not to damage the buccal plate. I try not to luxate to the buccal because that lets me preserve the hard and soft tissue. So here you see 2 perfectly clean sockets with 0 flap elevation. PRF block like you saw the last time, amnion chorion barrier, little PRF just over the exposed part to keep the patient away. We can leave the amnion chorion exposed. We have literature by Holtzclaw and others that show that. My cases show it. But in certain patients, I don't trust them, and I want to give them the extra hedging of the bet just to make sure that the amnion chorion doesn't get brushed away or chewed away. That's what we started with. New filling goes in. We try and get bone above the furcation and above the alveolar crest. You can see how beautifully the ridge heals on the left, and you can see we're going to place an implant with guided surgery. And if you look carefully under the guide, I am not going flapless. I want to keep every part of that keratinized tissue, and you'll see why in a minute. And again, we're now using, this is still with Marius and team, but now we're going to be switching on some of our cases and using a new software called Guide Mia. And again, any questions about anything, hardware, software, biologics, my email address is down there. Just please give me a buzz. Again, implants are planned. He actually was in for almost 4 hours the day we did this because we put 3 on the bottom, 1 on the top. Did soft tissue contour grafting. We did some orthodontic microperforations on him, and yeah, it was a heck of a visit. But again, we use our guided surgical planning to show us where the nerves are, where everything else is. Now look carefully at site number 30. Look at the cross section in the middle right side of the screen. Look at how we preserved and augmented that buccal plate. You can see the thick initial plate and how we grafted even crestally over the lingual plate with this graft material in a PRF block, amnion chorion barrier, and just the PRF to prevent him from brushing it away. Again, we have our aggressive taper. This one is the S+, the more aggressive thread, because this was more newly regenerated bone. Again, as you can see on the right side of the implant, that platform, the bone platform shift, so we can get more bone around our emergence profile. The S plus gives us more of a chamber, a bone chamber-like healing, almost like parallel flutes, and a very, very solid internal connection. I'm not worried about leaving these implants alone as single restorations, anterior or posterior. Look at all of that bone around that lower implant. And it was placed, you can see on the lingual, almost 2 millimeters subosseous. And you can see at least 3 or 4 millimeters on the lingual. And because we try to only elevate to almost the edge of the crest, he has almost 3 millimeters of bone to the buccal. And look at all that keratinized tissue on the right side of the screen. This is what you want around your implant. Again, Linkevicius has shown you want 3 millimeters of soft tissue around your implant to preserve crestal bone. Often we will do a staged graft, whether it's when we uncover or when we place an implant, just to augment the soft tissue thickness in these areas. So that was the graft healed. And as you can see, we managed to maintain that graft even at 4 to 6 months post-op above the alveolar crest. And that's the implant 1 month post-op. Actually, 4 hours ago, he was in my chair. And that's what it looks like. And you can see above the shoulder of the implant, you can see a couple of different densities of bone. So right below at the narrowest part of the implant, that's the 1.5 to 2 millimeters deep that the implant was buried, and above that is where it's grafted. And you can already see bone coming and growing over the shoulder of the implant, exactly the way the implant is designed. So one more case, another patient with a demolished socket. What do? We know what the patient's goals are. They don't want to be in our chair, but they want to be in our chair as little as possible and pay as little money. Looks a little like Bernard. So similar case, no keratinized tissue. This again did not happen yesterday, but I want to try and get it all back in one easy shot if I can. To do it, I have to elevate a flap in this case. I can't just regenerate 6 millimeters or 7 millimeters of keratinized tissue height. So yeah, that was not a simple one. Something happened, it fractured a long time ago. He's been dealing with medical issues in himself and his wife. We know there's no buccal plate. We know there's no lingual plate. So I'm going to do a PRF block of allograft. I'm going to try and take this gigantic hole and see how close I can get it to the height of the first and the third molars in just one surgical procedure. So again, look how close that base of the defect is to the inferior alveolar nerve. There's no way I can put an implant in that and expect, based on literature, to regenerate bone and attachment and have it osseointegrate. So let's see what we did. We're going to take the tooth out, we're going to debride the area, and we're going to rebuild, because this is not what we want. We don't want a loss of keratinized tissue. We don't want a loss of bone. We don't want to leave him with an area like this that he can't function with, that he will have drifting of the other teeth. He wants an implant. He wants a tooth. It's my job to give him the foundation for it. So we know we need bone. We know we need keratinized tissue. And I want to try and do it with as little flap manipulation as possible, because I don't want to damage the blood supply. So we take out the tooth. We try and get out all the gutta percha. We try and get out all the granulation tissue. And now we're going to move all of that soft tissue to the buccal. Whatever was there, I'm going to depend on to become new keratinized tissue. We're going to debride that giant hole and make it as clean as possible. We're going to make our same corticocancellous allograft PRF block, just like you saw before. In this case, we're also, for strength, because he's got very large muscles, we're going to add a collagen barrier over the top. Just because I'm afraid with his musculature, I want a little more rigidity. And then we close it. Now already you can see the tissue looks a little better. We've literally everted the granulation tissue to become our new buccal soft tissue. So we're not going for primary closure. We're not damaging the periosteum. That was the defect. That's the graft. Full attempt to regenerate buccal and lingual. Trying to get everything we can. And now we wait. We give them 3 months, 4 months, 5 months, 6 months. We do a CBCT when it looks like there's living vital bone density around the particles. Looks a heck of a lot better than when we started. We got pretty much everything back. Maybe we're down 1 millimeter on the distal of 30, but we got everything on 32. And look at that. Not bad for one shot. So let's quickly go through it. We plan out in 2D where we want the implant to go. We transmit that to Marius and his team to make the guide. And look at that ridge. Remember, he had no buccal, no lingual plate. Bleeds like bone, cuts like bone. So I'm showing you the guided surgery without the guide. So we did that. We placed the drill through the guide, drilled the hole, and I'm showing you exactly what it looks like without the guide so you can see where it is. So we've tried in the guide. We do a 2 millimeter pilot drill. We check it for fit, for angle and direction, and we know that everything is going properly. It's exactly where we want it. We continue drilling. This shows us as it would be with the guide in place. And again, the guide is only out so you can see it, that we're going to full depth. We harvest a little bone with these drills. That's another nice thing about the contact system, is you can get vital bone off it. Look at how much bone we have. We didn't lose anything. We had no bone to begin with. So we gained 6 to 7 millimeters of height on the buccal, and we now have 10 millimeters of width at the crest. So again, S+ aggressive tapered implant, rough hydrophilic surface. We want the stability. We want the bone chambers to give us the best healing. And we want that parallel surface. You can see buried 2 millimeters deep in that regenerated bone, and it's bleeding all the way throughout. This is not graft material inside connective tissue. This looks like real vital bleeding bone. So we have Boozer and Grunder's criteria. We have Linkevicius's criteria of 3 millimeters of soft tissue, and we have a very stable implant. So we're going to put a little contour grafting again, just to support the soft tissue. We surely don't need it for the implant. We're going to place the soft tissue back in place. Again, a little collagen over it just to help hold everything there. And look at that emergence profile. That's more than the 3 millimeters Linkevicius told us to. We get the restoration. You can see a long Morse taper to hold it with an anti-rotation portion, which is why these are so stable. We have the screw axis hold the exact way that Marius and I designed it for the ideal screw retain restoration. Again, guided surgery, quicker, easier for the dentist, gives us, whenever possible, the predictability for screw retain restorations. And there we have it. We have the restoration exactly where we want it, just like everything else. So the final restoration, we have plenty of keratinized tissue, plenty of bone. It looks like a tooth. It fits like a tooth. It flosses and it chews like a tooth. So why did we have success? We did guided bone regeneration. We did that based on the diagnosis and the materials. We used the ideal contact S+ implant with a hydrophilic bone holding surface into the regenerated bone. And then we used the ideal software and hardware to give us our guided surgery with the right team to help us plan and make the guide. And now he can maintain it. So I gave you a lot tonight. So we showed how we talk to a patient who has a fully intact dentition, but may end up losing some teeth. I showed you just one of multiple solutions using some graft materials, some growth enhancers, some bioactive, and some collagen barriers of what we can do to severely damaged sites. I showed you how we can restore and regenerate hard tissue and soft tissue. Using software, we can plan out our implants, generate our guides, and get ideal restorations screw retained exactly where we want them. That software, that planning allows us to get the surgical guide, and you saw it both in use and what it looks like with the guide not there. And you saw how that gives us simple, predictable implant placement to lead to screw retained restoration and a satisfied patient. So I think we've shown plenty. We took all sorts of damaged people and gave them really happy outcomes. So with that, I think it's time to answer some questions. So let us, I'm not sure how to get, there we go. Thank you. Thank you for returning me my mouse. And let's go to the Q&A. So, have I noticed more liver clots over my graft, non-resorbable membrane site since COVID? How do you treat and prevent these clots from happening? So number one, I have not seen any liver clots. Number two, I'm not using non-resorbable membranes. I'm only using resorbable membranes. So my assumption is the reason you're getting liver clots is you're having a lot of bleeding, and that's probably because you're raising flaps. As you saw, when I elevated a flap, even at the time of implant placement, it was only to just the very crest. When I had to elevate a flap at the time of extraction, it was only where I was trying to regenerate the ridge. It was not in general where I was doing a conventional extraction. How important do I feel checking ISQ is? Do you want to compare ISQ to CYA? I think it's a good idea because, so I'll give you, for instance, one of my patients, of course, it's my office manager's husband, his ISQ went downhill after implant placement, not with these implants, with other implants. He is on methotrexate, he's on prednisone. He's had implants fail twice in the same sites because of poor healing. I think that if I had an implant where the ISQ did not get stable enough when I thought it was time to load, I would leave it in there for longer. So is it critical? No, but I think it gives me another answer. June, my pleasure, as always. And by the way, June, you owe me x-rays from last Friday. Next one, is there a minimum width for implants in the first molar region to prevent fracture, or does it depend on implant brand? So I'll go last first. Implants, there's certain implants that are weaker grade titanium, certain implants that are stronger grade titanium. A lot of implants these days are titanium, aluminum, vanadium alloy. Most implants, I think, are alloy or the grade 4 extra hard implant. I think as long as you have a 4.2 millimeter implant or larger and decreased lateral forces, you should be fine with even that size implant in the first molar region. More and more of my patients over the years, higher percentage, have gotten night guards just to be on the safe side. Next question, Karine, why would you not recommend someday implants? I'm assuming you mean same day implants, like, yes, same day, like immediate loading. So Jeff Ganellis is a very good friend of mine, does a tremendous number of immediate socket, immediate load implants. I have a lot of older patients, a lot of medically compromised patients, a lot of poor plaque control patients. To me, it's just not worth the risk. Jeff, Bob Levine, Dennis Tarnow, all very good friends, co-researchers, lecturers, mentors of mine, all do it. Dan Cullum out in Idaho, and do it beautifully. To me, I just don't take the risk that often. How long after the surgery did I place the crown on the tooth number 31? So Dennis is diabetic and has a number of medical issues. I waited 6 months to place the implant and 5 months to restore it. Octavio, I will never restore without an ISQ reading. I agree. Again, I don't think it's absolutely necessary to have an ISQ, but it's just extra data that you can have. And I think that's all we have. That's all the questions. So if there is anything else, I think we have ended right on time.